Should I change the background?
Fine, sir, fine. Sir,
Okay.
we are live now. With all your permission, I'm starting. Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar that is on a very important topic that it targets of LDL lowering therapy in type 2 diabetes mellitus. Current evidence and recommendation. As we know that this topic is very important, so we need someone who is expert. So without any further delay, I would like to invite Dr. Anuj Maheshwari sir, and let me share some of the achievement of sir. Sir is professor in internal medicine, HIMS Lucknow, and adjunct professor in general medicine, KMC Manipal, and president of Asian and Pacific Society of Hypertension, and secretary general of Indian Society of Hypertension, and president elect of RSSDI, Research Society Study of Diabetes in India. So, without any further delay, I would like to invite sir and hand over this session to sir. Sir, webinar is over to you, sir. You can proceed from here.
Thank you, Faraz, and thank you, IGCP, for giving me this opportunity. Today, I shall be talking about targets of the LDL lowering therapy, especially in patients of type 2 diabetes. What the current evidences are with us and what are the recommendations. Most of the time, it is recommended that all type 2 diabetes patients, especially those who are 40 years or above, should be started with lipid lowering therapy, whether they are having their cholesterol level high or even in the normal range. They should always be or compulsorily should be kept on the statin therapy or should be kept on the lipid lowering therapy. But major question arises in the minds of most of the prescriber. Up to what level of the LDL we can lower it? And most of the time it is seen that lowering LDL less than 50, it always creating a lot of apprehension in the minds of the prescriber whether I should keep continuing lowering further or I should stop the lipid lowering therapy. Many of the times, patient and its relatives are also remaining in dilemma whether they should continue the lipid lowering therapy or it should be stopped. Whether it is really good to go less than 30 or less than 20 LDL or it is not acceptable. So we shall be finding the answer of all these questions in today's presentation. So what do we already know about the Indian diabetes population as per the ICMR in diabetes study that overall prevalence of the dyslipidemia in our country is 81.2%. Most common dyslipidemia is not high LDL in Indian population. In fact, it is the low HDL. HDL means high density lipoprotein, which is also known as the good cholesterol. Lower good cholesterol, lower level of the good cholesterol is most common dyslipidemia instead of the high level of the bad cholesterol. The prevalence of low HDL is 66.9%, while high LDL, which is usually targeted in rest of the world, with the lipid lowering therapy is having the prevalence in the Indian population only 20.9%, round about 21%. Both low HDL cholesterol and high triglycerides were uniformly prevalent across India, and high LDL cholesterol showed significant interstate variation. Means in some of the state it was high, in some of the state it was low, but overall high LDL cholesterol was not more than 21%. So if we look for the risk factors for the cardiovascular disease, why do we really want to reduce the cholesterol? Because it may lead to the heart attack, it may lead to the coronary artery disease, it may lead to the cardiovascular disease. That is the reason because of what we really wish to lower it down. But where this dyslipidemia stands in the list of risk factors for the cardiovascular disease. As per the list, this list, we understand that diabetes and hypertension are still the highest level of the risk for cardiovascular disease, and both are keeping at the same level, followed by lack of exercise, sedentary lifestyle, including even in the women in the house. It is the next risk factor which may lead to the heart problem or coronary artery disease, cardiovascular disorders. Fourth is the dyslipidemia. Dyslipidemia means higher level or abnormal level of the lipids in our vascular system or our blood. And this is especially in the type 2 diabetes. This is a joint killer with the diabetes. When we see that diabetes is already ranked in the top 10 highest at the risk factors for the cardiovascular disease. If the person is having high blood pressure also, then that risk is also there. And if we join the dyslipidemia with this, obviously this makes it very cumbersome and very difficult to manage situation if all the three are together and not being really treated. Studies have shown that India is not just the diabetes capital of the world, it also has the highest prevalence of the metabolic syndrome and obesity. So people with diabetes have a 2 to 3 fold higher risk of the heart diseases, and this diabetes is enough to increase the risk of the MI, congestive heart failure, peripheral arterial disease, increased chances of the stroke, and of course, overall mortality is simply being rising because of the presence of diabetes. But in Indian perspective, these dyslipidemia plays in a bit different way as compared to the rest of the world. In our country, LDL cholesterol abnormality is more of the qualitative than to the quantitative. We don't find more than 20.9% people those who are having abnormally high LDL cholesterol, but the qualitative abnormalities are there in majority of the people, especially those who are having diabetes, making them more atherogenic particles in the blood. They are smaller and more dense LDL particles. At the same time, they are more oxidized also. Apart from that, our Indian diabetics are having high level of the triglyceride and low level of the HDL cholesterol, which is the good cholesterol. No HDL cholesterol may be a better predictor. Non-HDL cholesterol, therefore, considered to be a better predictor of the risk of cardiovascular disease as compared to the LDL cholesterol, because quantitative measurement of the LDL cholesterol is not really giving any indication that patient may be prone to have the cardiovascular disorder highly. If we look for the gender differentiation, prevalence of the dyslipidemia in female is higher than the male. 97.8% females are having dyslipidemia with diabetes, while in male it is only 85.5% individuals having the diabetes presents with dyslipidemia. Now question arises, how does this atherogenic dyslipidemia in type 2 diabetes Indian patient starts with? Atherogenic means which may leads to the atherosclerosis. Dyslipidemia or variety of the dyslipidemia which may cause the atherosclerosis. It starts with the insulin resistance, and this insulin resistance is enough to increase the activity in the liver, through which liver keeps on making glucose and keeps on releasing the glucose, especially when it is not being available from the meal derived sources. So once the person is not eating or meal derived glucose is not there, liver is responsible to supply the glucose, but it keeps on doing its job excessively, and by doing that, lot of glucose is being released in patient's body, because of what control of that diabetes becomes difficult. At the same time, the person, it becomes the responsible for development of the type 2 diabetes also. Once this phenomena is happening, we see that more of the very low density lipoprotein is produced, which gets converted into the dietary intermediate density lipoprotein, and then we see that LDL, which is the small density lipoprotein, and all these three are supposed to reduce the catabolism in the liver. The only variety of the cholesterol which increases the catabolism is the high density lipoprotein, but it is supposed to be lower in the blood level in Indian population in the setting of the insulin resistance. So these are the triad of the diabetic dyslipidemia, which is also known as the atherogenic dyslipidemia. Means once we see that increased level of the small density LDL or small density lipoproteins, then together with increase the level of the triglyceride and reduce the level of the high density lipoprotein. The two things are higher than the desired level, a small LDL, high triglyceride, and one is lower than the desired level, that is the HDL or high density lipoprotein, or which is also known as the protective cholesterol or good cholesterol. So, how do we treat this kind of the situation? High LDL is leading to the increased cardiovascular risk, and the people, those who are having the diabetes, they are supposed to be on the higher risk diabetes even without target organ damage, having their diabetes more than 10 years or having some additional risk factor, they are supposed to be on the high increased cardiovascular risk, and they should be advised to keep their LDL cholesterol less than 70 milligram per deciliter, or whatever the level they are having, 50% reduction is required from that. On the other hand, the people, those who are already having the established atherosclerotic cardiovascular disease, having their score more than 10%, or having the familial hypercholesterolemia with atherosclerotic cardiovascular disease, CKD, chronic kidney disease, EGFR less than 30, diabetes with target organ damage, or having more than three major risk factors, or somewhere they have got the early onset of the type 1 diabetes, which is more than 20 years of the duration. They all are on the very high risk of the cardiovascular disease, and they are supposed to keep their LDL cholesterol level less than 55, and whatever level they are having, then it is supposed to be reduced to 50% of that. Means what I just want to say that if somebody is having very high risk and his cholesterol is already 50 or 60 or in between 50 or 60 milligram per deciliter. So somebody may have this idea that it is already on the normal level, then why should we add the statin or lipid lowering therapy? No, this patient is also required to be added lipid lowering therapy, and he should be brought more than 50% of the existing levels reduction. So this is if somebody is keeping himself on the 50 milligram per deciliter, having very high risk, then he should be brought to the 25 milligram per deciliter with the lipid lowering therapy. Randomized control trial data supports a direct linear relationship between LDL cholesterol level and coronary heart disease event rate. There is no clear lower limit for LDL cholesterol reduction and the related benefits to the coronary heart disease reduction. Means if somebody is keeping his residual level of the 50 milligram per deciliter of the LDL cholesterol, no lipid lowering therapy is going on, having Very high risk of the cardiovascular disease as per the criteria given on the last slide. You start the therapy to reduce its 50% reduction of the existing level. Means if somebody is having on a 50 milligram per deciliter, you will target to bring it down up to the 25. But question arises, if it starts going less than 25, then what should we do? There is the answer of this question is that there is no clear lower limit for the LDL cholesterol reduction and the related benefits to CHD reduction. So we should allow going as much low as possible of LDL cholesterol reduction by appropriate lipid lowering treatment. Let's come over to the management tips. LI, Lipid Association of the India, has given its guideline 2020, and for in their guidelines they have given an idea about the risk stratification. Is how do we establish the risk stratification? They have made three major categories of the risk factors. One category was including the major atherosclerotic cardiovascular disease risk factor, which includes if the person is keeping the age more than 45 years or 45 years in males and 55 years in females or more than that. If somebody is having the family history of the premature atherosclerotic cardiovascular disease, means somebody in the family might have had heart attack or a stroke, something like that, early as per the expectation of the early age. Current cigarette smoking, tobacco use, if somebody is having the high blood pressure and HDL cholesterol level is low. These are considered as a major atherosclerotic cardiovascular disease risk factor. So this is one category of the risk factor. Another category of the risk factor is other high risk features. Means if the person is having diabetes and having any one of the major atherosclerotic cardiovascular risk factors, what the five I have already enumerated in the first list. If somebody is having the chronic kidney disease, either it is stage 3B or 4. Third, if somebody is having the familial hypercholesterolemia, extreme of a single risk factor, coronary calcium score is 300 or more, non-stenotic cardiac carotid plaque, lipoprotein lipoprotein A more than 50 or more than 50 milligram per deciliter. If any of these things is there, this comes into the category of the other high risk features. Third category is the moderate risk non-conventional risk factor. That includes coronary calcium score between 100 to 299, increased carotid intima media thickness, lipoprotein A ranging between 20 to 49, impaired fasting glucose, increased waist circumference, apolipoprotein B more than 110 milligram per deciliter, HSCRP equivalent to or more than 2 milligram per liter. So now question arises, if we, how shall we use this three list of the risk factors in designating the risk of individual? Low risk. Low risk is that where a person is having any one of the major atherosclerotic cardiovascular risk factor and lifetime cardiovascular disease risk is less than 20%. Moderate risk is that where two major atherosclerotic cardiovascular disease risk factors are there from the first list together with or anyone is having low risk group with more than one moderate risk non-conventional risk factor. Moderate risk non-conventional risk factor is the third one. Then we shall consider the lifetime CVD risk more than 30%. High risk would be that where more than three or more than three major atherosclerotic cardiovascular disease risk factors from the first list would be there, or two major atherosclerotic cardiovascular disease risk factors with one or more than that moderate risk non-conventional risk factors from the third list is there, or more than one other high risk feature means second list are there. So any three from the first list, any two from the first list and one from the third list, and any one from the second list, which is the other high risk feature, is there, it is considered a high risk. Very high risk is those having the pre-existing atherosclerotic cardiovascular disease, those diabetics who are having more than two other major atherosclerotic cardiovascular risk factors. Other major cardiovascular risk factors are the risk factors which are enumerated in the second list, with familial homozygous hypercholesterolemia with evidence of the target organ damage. Extreme risk can be divided into the two categories, category A, category B. Category A is having coronary artery disease with one or more than that feature of the high risk group. Category B is the coronary artery disease with one or more than one feature of very high risk group, or recurrent uh, acute coronary syndrome within 1 year despite LDL cholesterol is keeping less than 50 milligram per deciliter, or a person may develop the polyvascular disease. Multiple vessels are involved in the atherosclerosis. So these are the way of stratification recommended by the Lipid Association of India, which is most appropriate for the Indian population. Now, if we look for the risk stratification, which has been suggested by the European Society of Cardiology in 2019, the very high risk category has been considered those who were having the documented cardiovascular disease, clinical or unequivocal on imaging, unequivocally documented cardiovascular disease on imaging, including the significant plaque on coronary angiography or carotid ultrasound, or having the diabetes with target organ damage like proteinuria, or with major risk factors such as smoking or marked hypercholesterolemia or marked hypertension. Fourth is the severe chronic kidney disease when GFR is less than 30, or a calculated score is 10% or more. These are the criteria for very high risk as per the European Society of Cardiology 2019 recommendation. The same recommendation has also defined the high risk, moderate risk, and low risk. High risk includes the criteria markedly elevated single risk factor, in particular cholesterol more than 310 milligram per deciliter, for example, that seen mostly in the familial hypercholesterolemia, or the person's blood pressure is ranging more than 180 systolic or 110 diastolic or more than that. Most other people, those who are having the diabetes, with the exception of young people with type 1 diabetes and without major risk factors, that may be at low or moderate risk, and people those who are having the moderate CKD, GFR ranging between 30 to 59, calculated score is more than 5% but less than 10%, is considered to be in the high risk. Moderate risk is that where the score is more than 1% but less than 5% at 10 years. Many middle-aged subjects belong to this category. Low risk is the score less than 1%. So if we try to do the comparison of various international guidelines with the recommendation of the LDL targets, we see that moderate risk, where the LDL targets have been defined by the European Society of the Cardiology guideline as well as ADA 2025 guideline. Young patients, those who are having less than 35 years age with type 1 diabetes or less than 50 years of age with type 2 diabetes. Duration of the diabetes is less than 10 years without any risk factor, keeping their LDL cholesterol less than 100 milligram per deciliter, they are considered as a moderate risk. Similarly, as per the ADA, which has defined the moderate risk people, those who are the target of the primary prevention, not having any atherosclerotic cardiovascular disease, diabetes patient ranging between 40 to 75 years, start moderate in, in moderate intensity statin therapy in addition to the lifestyle therapy. Diabetes patients, those who are ranging between 20 to 39 years of the age, with additional atherosclerotic cardiovascular disease risk factors, they should be initiating the therapy in addition to the lifestyle therapy. If patients are at a high risk, especially those with multiple atherosclerotic cardiovascular disease risk factors, having their age between 50 to 70 years, use high intensity statin therapy. If more than 20% atherosclerotic cardiovascular disease risk, add ezetimibe to the maximum statin dose, reduce LDL cholesterol by 50% or more than that. High risk category is defined by almost all the organizations except ADA. 2019 European Society Cardiology Guidelines say no target organ damage with diabetes duration more than 10 years plus any other additional risk factor is considered as a high risk dyslipidemia or high risk category of the dyslipidemia. In such patient, LDL cholesterol is recommended to keep less than 70 and LDL cholesterol reduction at least 50% of the baseline should be done. Non-HDL cholesterol less than 100 and ApoB less than 80 milligram per deciliter is recommended. LI, Lipid Association of the India 2020 guideline has suggested all high risk people, those who are having diabetes with one or more than one major atherosclerotic cardiovascular disease risk factor without any target organ damage, are advised to keep their LDL cholesterol less than 100, non-HDL cholesterol less than 130, and ApoB less than 90. ACE in American Association of Clinical Endocrinology in 2020 has suggested that high risk includes diabetes with no other major atherosclerotic cardiovascular risk factors, only diabetes, and together with age between 40 to 75 years. Means LDL cholesterol should be less than 100, non-HDL should be less than 130, ApoB should be less than 90, and triglyceride should be less than 150 milligram per deciliter. So these are the recommendations of the various organizations for the LDL target in different scenario or different risk category. So I just told you about the moderate risk category and high risk category. Now I shall be telling you about a very high risk category. Very high risk category, European Society of Cardiology guidelines say those who are having diabetes with established cardiovascular disease or target organ damage or three or more than that major risk factors or type 1 diabetes duration 20 years or more. They should be recommended to keep their LDL cholesterol less than 55, LDL cholesterol reduction at least percent, non-HDL cholesterol less than 85, and ApoB less than 65 is recommended to keep. Live in 2020, it's the recommendations for the very high risk category, which includes diabetes with more than two other major atherosclerotic cardiovascular disease risk factors or evidence of the target organ damage. They are recommended to keep the LDL cholesterol by lipid physician for India less than 80 milligram per deciliter, non-HDL cholesterol less than 100, and ApoB less than 80 again. American Association of the Clinical Endocrinology 2020 guideline suggests that very high risk factor includes the diabetes together with a major atherosclerotic cardiovascular disease risk factor or CKD 3, grade 3 or grade 4. They are advised to keep their LDL cholesterol less than 70, non-HDL cholesterol less than 100, ApoB less than 80, and triglycerides less than 150. ADA, for a very high risk factor, includes those who are looking for the secondary prevention for all ages with diabetes and atherosclerotic cardiovascular disease. Moderate intensity statin therapy with lifestyle recommendation is there. If LDL cholesterol is 70 or more than that on maximally tolerated statin, then it is a recommendation to add either ezetimibe or PCSK9 inhibitor. If statin not tolerated, you can not tolerated use maximum tolerated dose, whatever up to whatever level the statins could be tolerated, we can use that. If atherosclerotic cardiovascular disease and elevated triglyceride, which is ranging between 135 to 499, consider icosapent ethyl or omega 3 fatty acids with combination with omega 6 fatty acid. Extreme risk individuals. Extreme risk individuals are only recommended by the two organizations, Lipid Association of India and American Association of the Clinical Endocrinology. They say LI 2020 defines the extreme risk into the two categories, category A, category B. Category A is the atherosclerotic cardiovascular disease and diabetes with one or more than one risk factor for the atherosclerosis cardiovascular disease without target organ damage. They are recommended to keep their LDL cholesterol less than 50, non-HDL less than 80, ApoB less than 65. Category B is having the CAD and diabetes with two or more than that major atherosclerotic cardiovascular disease risk factors or target organ damage presence. LDL cholesterol is recommended to keep less than 30. Non-HDL cholesterol is to be recommended to keep less than 60, and ApoB 50 or less than 50 milligram per deciliter is to be maintained. ACE 2020 has defined the extreme risk category when the diabetes and cardiovascular disease are existing together. Recommended to keep the LDL cholesterol less than 55, non-HDL cholesterol less than 80, ApoB less than 65, triglyceride less than 150. So these are the various international guidelines which recommended their LDL targets in setting of the type 2 diabetes, especially in patients of the type 2 diabetes. LDL targets in type 2 diabetes patient with or without atherosclerotic cardiovascular disease. If we summarize or enumerate them, DM, diabetes mellitus without atherosclerotic cardiovascular disease, no target organ damage or less than one risk factor is considered as a high risk level and LDL goal should be less than 70. Target organ damage is already there with two risk factors or more than that. It is considered as a high risk, very high risk factor, less than 50 milligram per deciliter is the recommended LDL cholesterol goal. Diabetes with atherosclerotic cardiovascular disease. We can consider it without target organ damage or less than one major atherosclerotic cardiovascular disease risk factor. It is extreme risk group of the category A where the recommended LDL cholesterol level is less than 50. Optional, you can go less than 30 also. In another extreme risk group, which is the category B, where the diabetes is existing with the multiple vascular involvement for the atherosclerosis, target organ damage, or two or more than two atherosclerotic cardiovascular disease risk factors are present. Then LDL cholesterol recommended to be kept less than 30 milligram per deciliter. Non-HDL and ApoB targets in type 2 diabetes patient as per the recommendation of the Lipid Association of India. Category A, extreme risk group, recommended to keep the non-HDL less than 80, ApoB less than 65. Category B, recommended to keep the non-HDL less than 60, ApoB less than 50. Very high risk, recommended to keep non-HDL less than 80, but ApoB less than 65. High risk group is recommended to keep the non-HDL less than 100 and ApoB less than 80. Intervention strategy as a functional of total cardiovascular risk and LDL cholesterol level. How should we try to do the intervention, or how should we add the lipid lowering therapy? So, whenever we look for the cardiovascular risk score, if it is less than 1, keeping LDL cholesterol less than 70 or between 70 to 100, no lipid intervention is required. If it is between 100 to 155, only lifestyle modification would be sufficient. Even in 155 to 190, lifestyle modification would be enough if the total CV risk score is less than 1. Only more than 190 milligram per deciliter LDL cholesterol level shall be requiring for the drug initiation if it does not come down with lifestyle modification. If total cardiovascular risk score is ranging between 1 to 5, then less than 70 and between 70 to 100, lifestyle intervention should be followed. If patient ranges LDL cholesterol between 100 to 155 or between 155 to 190, lifestyle intervention considering the pharmacological drug therapy is recommended. More than 190, lifestyle intervention, pharmacological drug intervention is needed if it does not work up with the lifestyle intervention alone. Between 5 to 10, cardiovascular risk, or in case if it is high risk, more than 10 also, lifestyle intervention should be considered even at less than 70 milligram per deciliter of the cholesterol, together with drug pharmacological intervention. 70 to 100 would also be following the same recommendation, but in case of the 100 to 155 and cardiovascular risk score is between 5 to 10 or more than that, lifestyle intervention should be started immediate with the drug intervention. We should not wait for the lifestyle intervention to get its result. Drug treatment or lipid lowering therapy should be combined with the lifestyle intervention. In case if it is more than 10, then lifestyle intervention is recommended only less than 70. Still, you can consider the drug depending upon the condition of the patient. But after that, lifestyle intervention should be initiated together with the drug intervention in all classes of the dyslipidemia or disturbed LDL cholesterol. Effective management of the LDL in type 2 diabetes patient can be done by assessment of the cardiovascular risk. If the very high cardiovascular disease risk is there, obviously the start it is recommended to start the statin together with ezetimibe. If it is extremely high risk patient, then statin together with the ezetimibe PCSK9 should be added up to the targeted therapy. If and what should be the target should be less than 50% of the existing reduction value of the LDL cholesterol. Reduction more than 50% LDL cholesterol is considered to be the achieve the target which should be desired for that. If it is achieved, then we don't need to add any agent. But if it is not, then we should try to add the agent which has not been used as of now, maybe the PCSK9, maybe the bempedoic acid. In the setting of the diabetes, it makes it high, very high risk CVD. For the CVD, the statin should always be considered for the with the ezetimibe, so that more and more action of the statin could be derived. If it is not reaching to the LDL cholesterol goal, they are recommended to add the PCSK9 inhibitors, and if not, then bempedoic acid. And in the case of the residual hypertriglyceridemia is persisting, then IPE, pentathyl, is recommended in the dose of the 4 gram per day, or we can look for the fibrate. ApoB, non-HDL cholesterol, if not at the goal, then we can look for the modern therapies like NGPT, L3, NAB, and SOAP, APO, C3, ASO. So these are the therapies which are yet to come undergoing the cardiovascular outcome trial and can be used if the ApoB and non-HDLC is not at the goal in setting of the diabetes and cardiovascular disease when statin, ezetimibe, bempedoic acid are already being used. Treatment based on the expected reduction in LDL. When the patient with diabetes or with high risk of the diabetes with dyslipidemia, cardiovascular risk assessment and LDL cholesterol measurement is to be done, and expected reduction in LDL cholesterol, we can see that 50% reduction can be achieved by the statin therapy only, or pitavastatin is considered to be the most appropriate statin for the diabetes patient. 50 to 65% of the LDL reduction is achievable by statin combined with the ezetimibe. 65 to 80% is achievable if the statin ezetimibe combined with the bempedoic acid, and more than 80% if we really wish to achieve the LDL reduction, it should be added up with the PCSK9 modulators, either with bempedoic acid and without bempedoic acid. So, despite the intense lipid lowering therapy, when triglycerides are still keeping 200 or more than that, consider high dose omega 3 fatty acids, icosapentaethyl 2 to 4 gram per day, and alternatively, we can consider the fenofibrate also. What does the Lipid Association of the India recommends for the management of the diabetic dyslipidemia? The treatment approach emphasizes aggressive lifestyle intervention and control of the modifiable risk factor. Initial treatment includes moderate to high intensity statins for diabetes without atherosclerotic cardiovascular disease, and high intensity statins together with ezetimibe with fibrate FTG is 250 or more than that for diabetes with atherosclerotic cardiovascular disease. LDL cholesterol goals are met, but non-HDL cholesterol and FOB goals are not. Additional therapies like fibrates or icosapentaethyl 4 gram per day may be added. So this treatment algorithm for the diabetic dyslipidemia, which is recommended by the European Society of Cardiology in 2020, suggests that treatment of the diabetic dyslipidemia, together with the good glucose control, lifestyle modification, pharmacotherapies to be added up with the statin therapy, elevated if the elevated LDL cholesterol together with mixed dyslipidemia is there. In case it is only isolated hypertriglyceridemia, fibrate and omega 3 fatty acids are recommended. If it is only elevated LDL cholesterol or mixed dyslipidemia, statins must be started. Intolerance or LDL targets are not achieved. In case it is intolerance of statin or LDL targets are not achieved, ezetimibe could be used as a first line or it can be added to the statin. If we are not getting the statin tolerance, then ezetimibe would be the first line drug and PCSK9 could be used as a second line. In case the patient is not responding well, then bempedoic acid and inclisiran can be added to them. And in case of the isolated hypertriglyceridemia or hypertriglyceridemia is added a bit to the LDL cholesterol and there is a mixed dyslipidemia, then fibrates niacin should also be considered in its appropriate requirements or whenever they are desirable. RSSTI 2022 recommendation for the lipid lowering therapy. Stepwise management strategy for the Indian patient, those who are having the diabetic dyslipidemia. They say that stratify the risk for the atherosclerotic cardiovascular disease. If the age is less than 40 years, moderate risk atherosclerotic cardiovascular disease is there, or if it is more than 40 years of the age, then high risk atherosclerotic cardiovascular disease risk is there. And as per the ASCVD risk score, LDL goal should be for the patient at moderate risk, high risk, and very high risk should be targeted. Moderate risk it should be baseline to the 30%, baseline high risk for the baseline to the 50%, and for very high risk baseline to the more than 50% or equivalent to the HDL cholesterol is to be brought down. Triglyceride level should always be kept less than 150. As per the RSADI recommendation, initiation and escalation of the lipid lowering therapy based on the established goal is recommended to start with the moderate intensity statin, high intensity statin. Like moderate intensity statins include atorvastatin 10 to 20 milligram, rosuvastatin 5 to 10 milligram, simvastatin 20 to 40 milligram, pitavastatin 2 to 4 milligram, atorvastatin 40 to 80 milligram. While the high intensity lipid lowering agent includes the rosuvastatin 20 to 40 milligram. Ezetimibe when goals are not met with high intensity statin and PCSK9 inhibitors when to be used in patients with established atherosclerotic cardiovascular disease. Triglycerides includes the statins, fibrates. Triglycerides can be corrected with the statin, fibrate, saroglitazar, omega-3 fatty acids. They all can be used for the reduction of the triglycerides. The good thing is that only RSSDI in 2022 recommendation has included the saroglitazar for the correction of the hypertriglyceridemia. AI at the moderate or high intensity per CVD risk can be initiated when triglyceride is more than 200 milligram per deciliter. A recommendation of the diabetic dyslipidemia management, atherosclerotic cardiovascular, uh, European Society of the Cardiology 2019 recommendation in all patients with type 1 diabetes and in the presence of microalbuminuria and renal disease, LDL-C lowering at least 30% with statins as the first choice. Eventually, drug combination is recommended irrespective of the basal LDL cholesterol concentration. In patients with type 2 diabetes, CVD or CKD, and in those without CVD who are over the age of 40 years with the one or more other CVD risk factors or markers of the target organ damage. The recommended goal for LDL cholesterol is 1.8 millimole per liter, or in Indian perspective, we can take it less than 70 milligram per deciliter. And secondary goal for the non-HDL cholesterol less than 100 milligram per deciliter, or FOB is less than 80. In all people with type 2 diabetes, LDL cholesterol less than 100 is the primary target. Non-HDL cholesterol less than 130 and FOB should be less than 100 are the secondary target. ADA 2025, in its prevention and management of dyslipidemia, has suggested optimizing the glycemic management for people with diabetes. Most of the time, if you optimize the glycemic management, elevated triglyceride comes down on good control of the diabetes only. Low HDL cholesterol also gets corrected if it is less than 40 for men and less than 50 for women, simply by good glycemic control and following the lifestyle modification therapy, especially increasing the physical activity. Lipid profile should be done at the initiation of the statin or other lipid lowering therapy 4 to 12 weeks after the initiation of the therapy, or if you are planning any change in the dose, or after that we should keep on doing it annually every year. The lipid management for primary prevention of the atherosclerotic cardiovascular disease events in people with diabetes, in addition to the healthy behavior modification. In people between 20 to 39 years of the age, consider statin therapy if there are additional atherosclerotic cardiovascular disease risk factors. People having 40 to 75 years of the age, moderate intensity statin therapy in those without any atherosclerotic cardiovascular disease risk factor. You can use bempedoic acid for those who are statin intolerant. Otherwise, using you can start using a high intensity statin in those who are having the more than one atherosclerotic cardiovascular disease risk factor with an LDL cholesterol goal of keeping less than 70. It may be reasonable to add the ezetimibe or PCSK9 inhibitor to the maximum tolerated statin therapy if LDL goal is not met. In people more than 75, continue current statin therapy or consider initiating a moderate intensity statin after weighing benefits and risks of the therapy. Lipid management for the secondary prevention of atherosclerotic cardiovascular disease events in people with diabetes. Use lifestyle and high intensity statin therapy to reduce LDL cholesterol by more than 50% from baseline to a goal of less than 55 milligram per deciliter. You can add ezetimibe or a PCSK9 directed therapy with demonstrated benefit if LDL cholesterol goals are not met on maximum tolerated statin therapy. Use an alternative lipid lowering treatment for those who are statin intolerant. PCSK9 inhibitors with monoclonal antibody treatment and bempedoic acid PCSK9 inhibitor with siRNA in glycerin therapy could be used for as per the ADA recommendation 2025. Treatment of the other lipoprotein fractions or goal fasting triglyceride level 500 or more than that, evaluate for the secondary causes of hypertriglyceridemia, and consider medical therapy to reduce the risk of pancreatitis. Fasting triglyceride more than 150 or non-fasting triglyceride more than 175, address and treat lifestyle factors, obesity, and metabolic syndrome. Secondary factors include diabetes, chronic liver disease, kidney disease, or nephrotic syndrome, hypothyroidism. Medication that raise the triglyceride, atherosclerotic cardiovascular disease, or other cardiovascular risk factors on a statin with managed LDL cholesterol but elevated triglyceride ranging between 150 to 499. You can add icosapentaethyl to reduce the cardiovascular risk. Statin plus fibrate combination therapy could be good if we are having hypertriglyceridemia with hyperlipidemia or high level of the LDL cholesterol. But it has not been shown to improve the atherosclerotic cardiovascular disease outcome and is generally not recommended. Statin plus niacin combination therapy has also not been shown to provide additional cardiovascular benefit above statin therapy alone, may increase the risk of stroke with additional side effects and is generally not recommended. If we look for the rosuvastatin comparing with atorvastatin On new onset diabetes mellitus in patients treated with high intensity statin therapy for coronary artery disease. We understand it well. New onset diabetes mellitus among the patients who received high intensity statin therapy according to the statin group, and we could see that rosuvastatin was having little higher incidence of the new onset diabetes mellitus or naive diabetes mellitus as compared to the atorvastatin. So comparison of the guidelines for the statin used in type 2 diabetes patient. When to start a statin? ADA says that age 40 to 75 years with diabetes, start moderate statin, high intensity if multiple atherosclerotic cardiovascular disease risk factors or 10 years risk factors more than 20%. Moderate or high intensity statin is to be chosen depending on the risk of atherosclerotic cardiovascular disease. LDL cholesterol goals should be less than 70, and non-HDL cholesterol goal can be kept less than 100 for very high. American College of Cardiology and American Heart Association 2018 has given the recommendation to start a statin between 40 to 75 years of the age with diabetes patient. Statin irrespective of the baseline LDL cholesterol. High risk should be kept on the high intensity therapy. Otherwise, moderate intensity therapy could be sufficient enough. If more than two atherosclerotic cardiovascular risk enhancers are there, then only high intensity statin therapy is needed. LDL cholesterol, they have not specified LDL cholesterol goal. Aim for 50% reduction in LDL cholesterol if high risk. CAC score is being used if the decision is uncertain. European Society of Cardiology and European Atherosclerotic Society in 2019 has suggested all type 2 diabetes 40 years or more than that, having the duration of more than 10 years of the diabetes kept on the statin. Risk stratification should be done as moderate, high, or very high, and kept on high intensity statin therapy. Less than 70 should be the target of LDL cholesterol, and less than 55 should be the target for the very high risk category for LDL cholesterol. Other lipid targets includes the non-HDL cholesterol less than 100 and ApoB. And at the same time, if the very high risk category is there, then non-HDL cholesterol should be targeted to keep less than 85. Similarly, ACE and 2020 has recommended all diabetes patients are at least high risk to very high risk if atherosclerotic cardiovascular disease or more than two risk factors should be started on the moderate high risk statin therapy, and if they are in the very high risk category they should be started the high intensity statin therapy, keeping the LDL cholesterol less than 70, target less than 55 for the very high risk category. Other lipids mean ApoB can be kept at the less than 80 or less than 70. Triglyceride less than 150 is recommended to be kept. CDS 2023, all type 2 diabetes more than 40 years or with additional risk factors should be started the statin of the moderate or high intensity statin therapy, keeping LDL cholesterol less than 70 and moderate risk less than 100 could be allowed. Lipid panel monitoring should be done every 3 to 6 months. LAI 2020, Lipid Association of the India, suggests all type 2 diabetes patients more than 30 years of the age or any CV risk factors at any age group should be started with the statin. High risk gets intensive therapy, high or high, and they should be kept on the high for the high intensity statin therapy as well as for the very high risk group too, keeping the LDL cholesterol less than 70, and in the very high dose LDL cholesterol should be targeted to keep less than 55. ApoB should be targeted to keep less than 80. in very high risk category should be kept less than 65, or triglyceride should be targeted less than 150 milligram per deciliter. The effect of the anti-hyperglycemic drugs are also there on the lipoprotein. Metformin has no effect on the total cholesterol, but it reduces the LDL cholesterol. It also reduces the triglyceride, although having no effect on the HDL cholesterol. Sulfonylurea overall has no effect on any category of the cholesterol. GLP-1 analog has no effect on the total cholesterol, LDL and HDL. Only it has some effect on the triglyceride, fasting and postprandial. DPP-4 inhibitors, no effect on the cholesterol, only having some reducing impact on the triglyceride level. Acarbose is also having some reducing impact on the triglyceride level, although on the pioglitazone having some slightly reduction in the LDL cholesterol. It also increases the HDL cholesterol, and triglyceride is being brought down by pioglitazone. So pioglitazone is only drug which increases the HDL cholesterol. Rosiglitazone, again, no effect on total cholesterol, slight rise in the LDL cholesterol, slight rise in the HDL cholesterol, no effect on the triglyceride. SGLT2 inhibitors are seen with slight rise in the LDL cholesterol and slight rise in the HDL cholesterol. Insulin has no effect overall on the any variety of the cholesterol or triglyceride. So, a quarter of the century of treating LDL cholesterol, we could understand high is bad, average is not good, lower is better, and even lower is even better. Lowest is the best. So this is the ultimate message. As much as the LDL cholesterol could be kept, that is in the best interest of the individual as far as the cardiovascular disease is concerned. Thank you very much for your kind listening.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take this question one by one? Sir, we have received some permission. Shall we take these questions? Hello. Hello, sir. Can you hear me?
Yes, I can listen you.
Sir, there are some questions, sir. Shall we take?
Yes, yes, yes.
The first question I can see, sir, is related to, sir, how should we
Can I read the question,
sir, can I speak, sir?
or you will speak?
Yes, sir. How should we individualize LDC goals in diabetic patient with additional risk factors such as CKD, hypertension, or established ASCVD?
How? Please repeat the question.
The question is, sir, how should we individualize LDLC goals in diabetic patient with additional risk factor such as CKD, hypertension, and established ASVD?
Hypertension and
ASVD,
established
sir.
atherosclerotic cardiovascular disease.
Yes, sir.
Established SCACVD. Yes. Hypertension and established. So these are the people who would be finding themselves in the very high risk category. Those who are having the established atherosclerotic cardiovascular disease, and in fact, they are not the target of the primary prevention. They are the target of the secondary prevention because they have already got the atherosclerotic cardiovascular disease. At the same time, they are also having the hypertension. Diabetes is there or not? No diabetes.
Yes, sir.
So
Diabetes also.
So even in the absence of the diabetes, if somebody is being targeted for the secondary prevention, it is again the high risk category, very high risk category to be considered, and maximum tolerated statin therapy is to be given. If it does not work out to be keep the LDL cholesterol less than 55, we should add the ezetimibe or PCSK9.
Thank you so much, sir. One more question from Aarti Sharma. If HDL is 61 and LDL is 169, triglycerides normal, HbA1c 5.7, what should be done, sir?
When the patient is diabetic, still HbA1c is 5.7. This is that
Yes, sir.
patient
Yes,
is
sir.
diabetic.
No, sir. Question is, if HDL is 61 and LDL is 169, triglycerides normal, HbA1c 5.7, what should be done, sir? This is a
Yeah,
question.
non-diabetic range. And what is the level of LDL cholesterol?
Sir, like HDL is 61 and LDL is 169.
169. LDL is 169. Yeah.
Yes, sir.
So this is the candidate for the uh, high intensity therapy for the LDL cholesterol reduction to be done less than 70, and we should target to keep it less than 70 milligram per deciliter by reaching out through the high intensity statin therapy.
Thank you so much, sir, for answering the questions of participants, sir. Sir, as I can see, there is no more questions, sir. With all your permission, shall we conclude this session for today? So, shall we conclude this?
Okay,
Hello.
thank you. So,
Okay, sir.
can I
And sir, we would.
disconnect now?
Yes, sir. We would like to see you in future also with different topics, sir. Till then, take care of yourself. It was great honor to host you, sir. Thank you so much.